Hello, and welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Physician associates have been working in New Zealand for a number of years, and when I last checked, the Physician Associate Society had 50 members in New Zealand. This government has clearly signalled that they want PAs, physician associates, to be trained here from next year and that they be registered by the Medical Council. So today we're discussing some lessons that can be taken from the UK as to how New Zealand could develop clear and safe regulation to allow physician assistants to be integrated into our healthcare teams. We are privileged today to have in the studio Dr. Rob Hendry, the Medical Protection CMO from the UK. So Rob has been with MPS for many years and has a background originally in general practice. He has a global role with MPS and is very aware of the New Zealand jurisdiction. He's also very knowledgeable, well done Rob, of the issues in the UK. So thank you for joining us today. We're very grateful to have you here. And we also have Lucy Gibbard, medico-legal consultant with MPS, and Lucy has also been with MPS for a long time now. And my name is Tim Cookson, and I'm a former medico-legal consultant with MPS. So, Rob, let's kick off with you. What are the reasons that PAs were introduced originally in the UK?
Hi, Tim and Lucy. Very good to be here with you today talking about this. The reality, of course, is in the UK we've had a chronic underproduction of doctors for many years, and indeed recently more than half of the new registrations on the Medical Council's register have been doctors trained outside the UK. So there's been a real manpower crisis in the National Health Service, particularly in general practice. So one of the ways to alleviate this manpower shortage was the introduction of physician associates some years ago, probably about the early 2000s, and they were seen as a quick way, because of their more rapid training, to try to plug some of these manpower shortages.
And what's happened with the numbers of PAs during that time?
Well, there's been a gradual increase. I mean, the numbers still remain very small compared to the other healthcare professionals in the health service, but there's been a increase with a targeted number of about 10,000 in the NHS workforce plan over the next 10 years. And in response to this, a number of universities in the UK have set up training courses for PAs.
Look, I know there are a lot of uncertainties in New Zealand around physician associates. What were the concerns in the UK arising from this, from their introduction?
Yeah, I mean, it's been a very interesting history, really, because, as I say, the numbers of PAs started slowly in the early 2000s. And to begin with, there really was very little controversy about their roles. Something seems to have happened really around the time of COVID, when there was a lot of unhappiness in the medical workforce. As I say, the NHS workforce plan came out saying there was to be a large expansion, and that seemed to give rise to a number of concerns around clarity of the roles, as to whether these roles would have impacts on doctors in training, and a number of people raised questions about the safety of PAs seeing patients.
And so this is, doctors were concerned about the safety of the patients, yep. Was that then sort of regarded by some as being patch protection, that doctors wanted to look after their own? There's been a bit of a history of that over the years. So.
Well, I mean, it's difficult to say, isn't it? I mean, there was no doubt there was a lot of unhappiness in the medical profession, especially junior doctors or resident doctors, as we now refer to them in the UK, who were worried about the impact on access to training and so forth. And as I say, particularly around the COVID time, when there was huge stress on the workforce, they did raise some concerns. And sadly, in some areas, there did seem to be a bit of tension between the professions.
And were there any sort of significant cases that would have led to the concerns, that weren't just theoretical concerns, but actual concerns?
Yeah, well, again, I think because of the toxic discussion that seemed to develop around this area, the media obviously picked up on it, and there was a number of cases reported in the press which seemed to give rise to concerns, particularly when patients or the relatives said that they thought they were seeing a doctor when in fact they'd seen a PA. But if the media is often not the best place to play out these disputes, is it? And I think it really the tone of some of the debate really became pretty upsetting for everyone.
So this was media hype rather than real issues?
Well, the sad thing was a lot of PAs were seen to be contributing really well in some multidisciplinary teams, working away well, and the amount of heat that was generated in some of these media discussions, I think, really didn't do anything to help the situation.
I mean, it's easy to point at PAs making a mistake in diagnosis, but I think we can all agree that doctors make mistakes in diagnosis and management plans as well, don't we? I mean, it's if you're pointing to individual cases, it could be any health practitioner that can make mistakes.
Absolutely. The doctor who says they've never made a mistake has clearly got memory problems.
Yeah, exactly. We're worried about them.
That doesn't happen. So often it seems in the UK that if there's a lot of media hype, there's an inquiry that immediately follows.
We do love an inquiry.
The UK does inquiries, do they? Yeah, good. And I understand that in autumn of 2024 last year, in the light of this debate, the Secretary of State for Health and Social Care in the UK established an independent review to inform or to help inform a refreshed workforce plan. So this is called the Leng report, which has just been published. And the report, first of all, noted the lack of good research in this area, particularly around safety and effectiveness, so the very things we've been talking about. And look, there were 18 recommendations from the Leng report. We won't look at all of those. I understand many related to anaesthetics specifically, but we will look at 6 of the recommendations. So the first one was to rename to physician assistants. Now, really, is this a biggie, to go from associate to an assistant? Why was this? And why was it thought important?
Yeah, I mean, Gillian Leng really went to great lengths in her report to try to balance the interests and concerns of the various constituents, although, as she herself said in the report, she didn't think she'd be able to please everyone and that there might be a bit of controversy. As you say, she was looking at reviewing the evidence for the safety of deploying PAs, both in general practice and in secondary care. And one of the things that came through was the really poor, or the paucity of evidence one way or the other. It was almost impossible for the review to conclude whether or not deploying PAs was safe. In fact, a number of things did come out. Patients generally had quite positive experiences with their interactions with PAs. But 3 things she picked up on around this question of the difference between a PA and a doctor. And the first was the lack of clarity about the role. Patients in general didn't really understand what a PA was. Obviously, it's quite a new profession to the UK. So there was some confusion about whether patients had seen a PA or a doctor. Secondly, there was sometimes a bit of confusion about whether the person they'd seen could provide a prescription or not. And that seemed to cause a barrier to care sometimes. And then thirdly, I think arising from this confusion about titles, some patients expressed a lack of confidence that they'd seen the most appropriate healthcare worker. So, off the back of that, there was a suggestion that physician associates ought to be renamed physician assistants to stress the fact that people with that role were not doctors and were there in a supportive capacity when seeing patients.
So that's in the UK. What about New Zealand, Lucy?
Well, at the moment, they're called physician associates. I noticed there was a slip-up at the beginning when you said assistants at the very beginning, and it's really, and probably some people use one name and some people use another, and, a rose by any other name would smell a sweet kind of thing. We're left with what does the name matter? And I think the name is less important than the understanding of what it means. And I think that the patients may be said, you're being seen by a fellow. And they say, well, what kind of person is a fellow, or a registrar, or a house surgeon, or, patients often have very little understanding of the roles within the hospitals. And I think having the word physician in there makes people think it's a medical specialist, because that's the word we use for a medical specialist. So I think that is confusing to some people. But the study, the Leng report showed that some patients were told, I am a physician assistant, I am not a doctor, and they were still confused, And so actually it's not just the name. You actually have to do more than that, I think, as far as educating the healthcare team, but also educating the population as to what the role is and what it means. And it would be lovely to have a Te Reo name in New Zealand, wouldn't it be? Or an Aotearoa, I mean, I'm not sure what our medical council recommendations will be, but I think physician associate does potentially create problems.
Well, I guess this really is at the heart of responsibility, isn't it? And, who ultimately takes responsibility if something goes wrong. And so words are actually quite important, aren't they? Because I think of an associate as being someone on a kind of the same level as, whoever they're associating with. Whereas assistant, it's quite clear that they're helping someone as opposed to taking full responsibility themselves. So maybe from that point of view, actually, it's not just, words, but the semantics are important.
Yeah, and I think it is part of a wider challenge in healthcare as the multidisciplinary teams expand with many roles coming in. I think our patients will struggle to understand things. We've seen much less noise around the development of nurse practitioners' roles in practice and in healthcare. But even there, it may be that because of the use of the word nurse, a patient will see anybody with the nurse in the name as having a similar role. But of course, the emergence of nurse specialists, nurse practitioners and so forth, again, I think require people to explain what that role is and how they fit into that broader team.
It was interesting that I was in the Leng report towards the end, there's a discussion about whether or not everyone should have the same, a nationally mandated uniform, so that you're in one colour if you're a doctor, another colour if you're a nurse, another colour, or national mandated lanyards, or some way of everybody being identifiable by how they look.
Quite a kaleidoscope then.
You can imagine. But
and patients get a little colour chart when they go into hospital just so that they know who to recognise. Yeah,
exactly. I do think in looking at the complaints that come into MPS in New Zealand, it is not uncommon now for there to be a confusion when patients have seen maybe a nurse prescriber or maybe a nurse practitioner or maybe a health improvement practitioner or a health coach, and they have assumed wrongly what the role of that person was. And the complaint is just about something that's happened in the care. But then you get left with, and you have to correct them as to who they saw. And you kind of think, we're creating a whole nother complaint now, because actually the person in their complaint has said, I saw Dr. So-and-so, or I saw this nurse practitioner. In fact, they hadn't. That wasn't who they'd seen. So I think that introduction every time. And I think often when a new person's brought into a practice, for the first 3 months, the receptionists are busy saying, this is what this role is, this is who he or she is. But often we get so used to it and what everybody is that we assume our patients have got used to it too. And often they haven't, and they don't know who they're seeing.
And the landscape is getting more complex, isn't it, for patients? So if you think about it in general practice, you've got the GP, you've got the practice nurse, you've got the nurse practitioner, you've got the nurse prescriber, and you've got the physician associate.
And you've got the health improvement practitioner
and
the health coach. It keeps going. It is very complicated. And I know it's one of the things I've seen on an HDC opinion is that it's really important that people are introduced and that they know who they are consulting with.
So that kind of leads us on to the role of the physician associates, and this was recommendation 2 from the Leng report, that all healthcare providers increase in knowledge and skill, and as part of our lifelong work, and of course the same with physician associates. So, for example, doctors and nurses must be signed off to perform certain procedures independently, and it makes sense that this should be the same with PAs. In health, we use the apprentice model, which generally works pretty well, and reliant on a vertical team, and that's certainly the case in hospitals where this is the norm. So does it work well in hospitals, Rob? What are the concerns in hospitals in the UK dealing with PAs?
Yes, I think one of the areas of tension has been, I think, this potential conflict between training pathways for PAs and younger doctors. I think it would be fair to say that many units have worked very well with the PAs that are in them, and have found them to be valued members of the team. But in other areas, there has been a suggestion that if some of the simpler procedures are only done by PAs, it robs younger doctors of the opportunity to train on the simpler techniques first. But in many ways, I think this probably isn't the PA's fault, if you like. It probably points to the fact that medical training, certainly in the UK, and I'd be interested in you guys' views of the New Zealand's perspective, but certainly in the UK, the way training opportunities are presented for juniors, the level of supervision they get, the things that they're able to do to progress their skills, has shown to be quite wanting. And I think that is at the root of a lot of the current unhappiness. And as you know, we're having resident doctors going on strike in the UK, which is very sad. So I think some of the tensions that have been directed towards the relationship between doctors and PAs actually points to a broader concern and malaise, if you like, in the way we look after our younger doctors and help them with training.
So that's sort of in the hospital situation. Like, my understanding in New Zealand is that virtually all our PAs are in primary care rather than in hospitals. Lucy, do you see any issues with PAs in primary care with this kind of model of apprenticeship
with
model?
The credentialing model, with actually, because I think that this recommendation too is about having credentialing, so that you actually say this is someone who's trained for a specific aspect of their job, and maybe then being credentialed in different areas of management and treatment, and then saying, well, once you've been credentialed, then you can do that bit, which seems a very sensible way to do it. I think in New Zealand at the moment, a lot of the physician associates who've come in are very experienced, so that actually we've kind of inherited a workforce that have had experience before they've come here. And I think that's a very different situation from if people are coming straight out of a course where they've done their 2-year training course. And then I think we are going to need a really good system to make sure that they're then trained, as you would with any junior doctor that comes out of medical school, those first 2 years where they're pre-registration and actually learning the skills of actual practice. I assume that will be a similar thing, but again, it's to be decided in New Zealand. But I think because we've inherited quite an experienced workforce, it hasn't been so much the thing here.
And that's kind of both good and bad, isn't it? Because, if you've got someone who's obviously experienced, then, say as a GP and a PA started working in the practice, then I might very rapidly come to rely on them more than what actually was justified. And of course, with ultimate responsibility if anything goes wrong, still lying with the GP, then if the HDC is involved, the GP is going to be in the spotlight even more than perhaps the individual who might have made an error, which, as you've said, any of us can make, but it's where the responsibility lies. So,
and it's a little bit harder credentialing in general practice, I think. Whereas in the hospital, when you're in that vertical team, you're often working alongside someone else. Whereas in general practice, we're often in our own rooms just with a patient, and so you haven't got so much opportunity to watch other people consulting, unless you put a significant amount of manpower into actually doing that and the supervising. And the problem is that so often, as Rob said at the beginning, the physician associates are being used because real lack of workforce. And so if you're going to a place where there's a lack of workforce, then you're probably going to have a lack of people available to supervise as well. So it is a difficult situation. But I think the idea of having a clear credentialing system seems like a very good one.
Yeah, I agree. In general practice, there aren't actually a huge number of things that we actually would be credentialed for, are there? Most of our work is of a very general nature, so it's you kind of credentialed to be a general practitioner, a primary care physician, rather than for specific procedures. So it's actually quite a different kind of process. Yeah.
Well, they've brought in things like LARCs, marina insertions and things like that. So, I mean, I'm sure there are areas where that would be a useful thing. But I think it's time to do that is going to be the issue, and how to make sure that there's consistency in that supervision and in the credentialing within the practices, because clearly the practices are going to want to be able to credential people to do things if there's a lack of anyone else, And it was interesting because at the beginning of the Leng report, they said one of the things that physician associates have done in the UK is actually improve access. When there was no appointment to see a doctor, they can see a physician associate. So improving access was one of the positives that they did note. And obviously that's what we want to be able to do, is have our patients be able to access care.
I think you're absolutely right. And we know that the pressure in primary care is incredible, and it's only going to get worse, isn't it?
Thanks, Rob.
It's a very cheerful note. So I think you're right. How on earth we put together these multidisciplinary teams is quite a challenge. It's perhaps unfortunate that some of this was thought about after the event rather than in advance of it. But there's no doubt if we can credential specific areas to give people, I suppose, clarity and confidence in this area, it would be, to everyone's advantage, as you say, by increasing access, by alleviating some of the pressures on the medical workforce, and really being part of a more supportive team to make it sustainable. And
making sure there are supervisors available, and that the supervisors are not expected to do the supervision in their lunch hour and after work, that there's actually time to do it. And that maybe the supervisors get some training as to how to supervise, and what's expected in that role and what their responsibilities, and with MPS hat on, what their medical legal responsibilities are when they're a supervisor.
Because that's going to be different from, for example, having a medical student or having a registrar within the practice, the different levels of competence and so on. Yep. So career development is obviously sort of fairly critical for PAs, and that was certainly one of the recommendations, number 3 in the report, which was to establish an advanced physician assistant role, as we've discussed, this certainly makes sense. We won't go into any more detail on that. The next recommendation, number 4, related to undifferentiated patients. Now, that for us in general practice is about 99.9% of the time. And it certainly is a biggie. And so the recommendation was that PAs should not see undifferentiated patients except within clearly defined roles. And I guess we've had that example in general practice for some time, with nurses' roles being able to independently do certain things. But Rob, what was the rationale behind that? Do you want to expand on that?
Yeah, as we were saying, Leng was trying to look at the evidence for the effectiveness and the safety of PAs in various settings, and the quality of the research and the quality of the data was really quite poor. And I think that calls for further research in due course, but that's maybe something to talk about later. But one of the issues that she did alight on was that the fact whether there had been safety concerns in relation to PAs, they were almost always about either making or failing to make a diagnosis at the initial presentation of a patient, particularly either in primary care or in the ED department. And there were some cases reported, again, largely anecdotally, but the risk was of missing something that's unusual, which might have been picked up by a doctor who's perhaps trained in that in that way. Now, as we acknowledge, doctors don't always get it right. And certainly at MPS, we see examples both in secondary care and primary care where people have missed things. But I suppose you can see that from the public's perspective, if something is missed, inevitably they're going to say, if only they'd seen a doctor. Now, whether it would have worked or not is perhaps another question. But certainly I know as a GP myself, the core skill I suppose we develop in our fairly lengthy training is the ability to deal with undifferentiated cases, deal with uncertainty, and be able to have almost that sixth sense sometimes of knowing that there's a problem. So the recommendation coming out of Leng was very much that PAs ought not to see undifferentiated patients, that they should be triaged prior to being left with the patient to get on with whatever treatment's required. And that was both in primary and secondary care.
And certainly I can think of a case in New Zealand where a very experienced PA saw a patient, no triage before, didn't recognise something unusual completely outside their previous experience. And the problem there was that there was no good communication between the PA and the GP about it. So there was no discussion about the case. And it was something that the GP felt that they would have recognised, looking at the notes, they would have recognised actually there's something more serious going on here and would have changed the outcome. So that comes both to the supervision aspect that you were talking about, Lucy, but also, just what cases they should be able to see.
Yeah. So what the actual wording says, the PA should not see undifferentiated patients unless triaged into adult patients with minor ailments and within clearly defined clinical protocols as agreed by the colleges, basically. So they're saying, there is some situations where maybe they could see, but they're adults, they're triaged, and there are some really good protocols that say this is how you manage those cases, and it has to be minor ailments. The problem is, how do you know when someone's got a minor ailment before you've seen them? It's really hard, isn't it?
Well, absolutely, and we've all had those horrible feelings, haven't we? We've seen some we thought there's nothing very seriously wrong, and then the next day one of our partners tells us they saw them in the night and they were much worse. And certainly I find that quite stressful. I suppose the commonest area where that was concerned was with kids, wasn't it?
Yeah.
The feverish child and so forth. And clearly the suggestion there is they ought not to be seeing sick kids on their own, for the first time. And certainly the Royal College of Paediatrics and Child Health have said PAs ought not to be involved in the care of sick children in the first instance.
So there's quite a lot of work going to be needed to develop all the relevant protocols and things out there for the for that level of skill that the PAs have. Is it going to work in primary care, Lucy?
Well, look, I mean, there are PAs, lots of PAs working in primary care. I think that if these recommendations, obviously in New Zealand, we don't have, our medical council are going through the process of developing what the role is going to look like in New Zealand. And it may be that they come to a different conclusion from what they've come to in the UK. At the moment we don't know what it's going to look like in New Zealand, and I'm sure that the Leng report will be looked at, but we may come to some different conclusions. We may find that we have a different, unique environment here. But I think everyone has at heart the wish first that the PAs are properly supported, and that our patients are safe. And so, yes, I think there is going to be a lot of work to do on making sure that the processes and the protocols are there to do that.
But certainly talking to GPs who have had good PAs working with them, they're just absolutely delighted with the work that they do and the role that they play in the practice. So, clearly lots of benefits to be had. But our role, obviously, at MPS is to look at the potential risks. And
that is exactly. And I think there's no doubt that the old model of the GP working with maybe a practice nurse and a receptionist and them being the core of the people who look after that patient has already mostly, I mean, there's probably some places where it's still there, but mostly that role's gone. It is a multidisciplinary team. We do have people going to diabetes clinic and asthma clinic and, and having a walk-in clinic for the urgent stuff rather than one person doing everything. We haven't got enough GPs for the one GP to do everything.
And certainly the number of our current GPs who will no longer be GPs within the next 10 years, there's a huge hole that definitely needs to be filled.
So it may be that the GPs will be really in a supervision role almost, in a consultancy role where they are kind of overseeing. But I think the other thing that they talked about was that continuity of care thing, because in times past, the GP was the continuity of care. And if we're losing that, who is the continuity of care? And the question is, do GPs, what do they want? What do they value in their roles? Do they want to still be the continuity of care person? Do they want to be the person that sees the patient regularly? We know there's a significant mortality benefit if you know your GP and they've known you for a long time. Do GPs want that to change?
For me as a GP, that was the biggest thing, actually, was seeing people that I'd seen for 15, 20 years, knew them well, been through a whole lot of different crises perhaps with them. And that was the rewarding bit. It wasn't just seeing a face coming in. It was seeing that person that I kind of had that relationship with. And that, I think if we lack that personal reward from our work, then, general practice is going to be much the poorer for it. So, you're right. A lot of thought is going to need to go into that, because if you've got someone who's seeing, 3/4 of the consultations for your patient,
they're going to have continuity of care with the patients, and you're not anyway.
Yeah, exactly.
But of course, the patients might appreciate a long-term relationship
with the and that's what they were saying in the Leng report, that they do. They're good communicators, and they form long-term relationships.
Yep. And I presume they will have similar feelings to what I did in general practice, and that'll be their, personal reward will be having those long-term relationships. Yeah. So from that perspective, ought to be encouraged rather than discouraged. Yeah. Because you want happy people working in your practice. And certainly the Leng report considered deployment in primary care, and under recommendation 5, recommended that following graduation, at least 2 years of hospital experience was needed before moving into either primary care or mental health. So look, Rob, they found that the Leng report found that there's definitely strengths that the PAs have. Are you able to expand on those specific strengths?
Yeah, and I think, it's important to remember that I think Leng was looking at the issue of PAs who would be trained in the UK and coming out of the courses there, because I'm very conscious that in New Zealand, a lot of the PAs you have here at the moment will probably be experienced people that have come, often trained in America. So I think we just have to be careful that we're, not comparing apples and pears when we think about some of these things. But certainly there was no doubt the research that Leng picked up on showed that PAs were often very good communicators, often perhaps more empathetic than doctors, and they were very good at getting messages over to patients and so forth. So they looked at areas, particularly in primary care, around things like smoking cessation, dietary advice, and so forth, and certainly following up at-risk patients often felt very well supported. So that was good. But again, I think it was this idea that it would make sense, certainly for fresh graduates, if you like, to rather than going straight into primary care or mental health setting, to have a couple of years in a hospital setting just to get a bit more experience. And that's kind of akin to what you'd expect for a new medical graduate anyway. So I would hope that wouldn't be particularly controversial or difficult to achieve.
And certainly that is one of the concerns in New Zealand at the moment, is that the training that the PAs who have come to New Zealand have varies so much that you can't say, yes, a PA has this level of competence when they enter the practice. And it would be very nice to have something more consistent to be able to go with. In New Zealand, Lucy, in primary care, how's this going to work in terms of supervising and that sort of stuff.
Well, I think back to Rob's point is that currently the people we've got who've come from overseas have often been very experienced. So it's not, so that whole idea of this pre-registration time in hospital isn't quite so relevant for them. But I think the problem with, if people are doing a course in New Zealand where they've done their 2-year course, I think they will need time in hospital to learn more clinical care, on the ground, understanding of systems. The problem is that doesn't necessarily translate to the same kind of thing that we do in general practice. They'll obviously get more understanding about diagnosis and management, but sometimes it's not the diagnosis and management that's the same in primary care. So I'm not sure. I'm not sure if I think the reason for it is because it's easier to do. It's close supervision in hospital because you're working with others. You've got vertical teams. There's somebody else there all the time. In primary care, doing on one-on-one supervision for a lot of hours a day, where's the capacity for that? I think that's the problem.
And certainly, I think we've all experienced the major culture shock going from working in hospitals to going into general practice. So it'll be the same for them. So it does really, I guess, raise that question of just how valuable will it be for PAs who are wanting to work in primary care in New Zealand to have hospital, extra hospital experience over and above their training.
You look at the GPEP ones, the registrars who are coming out of the hospital system to do their first year in general practice, and there is a lot, especially at the beginning, there's an awful lot of support, an awful lot of cases being discussed, and a lot of teaching. It is a big transition, and as I say, I'm not sure how much the equivalence is relevant. And I also think the idea that, the Leng report talks about lifestyle management and, smoking cessation and dietary changes and things like that. There are probably other people doing those roles in general practice in New Zealand already. I think we have the health improvement practitioners who do quite a lot of that, and some nurses do quite a lot of that. And so if we're thinking about what the need within that primary healthcare team is, it will be different in different teams and in different areas. But I think that's not necessarily where they're needed. I don't know. What do you think, Tim? Do you agree? It's
a challenging one, isn't it? Because I was just thinking about the problem with you need the time to be able to really supervise well and educate. But the whole reason we need people like PAs is because we don't have the time.
Yeah.
And that's one of those awful catch-22s that I think we're going to really struggle with as a health system. But we definitely need to pursue it because we absolutely need good people providing the roles that traditionally trained GPs are no longer able to do. So in terms of supervision, the Leng report recommends that there be a clear line of responsibility with a senior clinician who's sort of aware of all of their roles and responsibilities and accountabilities. Are there formal guidelines yet in the UK for this, or are they still being developed following the report?
Yeah, I mean, that one of the challenges really particularly to the colleges, Royal Colleges, is to come forward with clear guidelines about how scope of practice is developed and how PAs ought to be supervised. As I was saying earlier, I think one of the lessons perhaps for New Zealand is that these things ought to be in place before there's widespread production of PAs from your own university and things. I think a lesson that we've seen is really we've slightly put the cart before the horse by not thinking around how should supervision be done, how much time should people be given to do it, who's appropriate to do this. And a lot of the junior doctors' frustrations have been the fact that they're often asked to supervise somebody at short notice without any proper training or clarity of what those guidelines are. So, as I say, the various colleges, particularly the College of GPs, I think needs to think this one through, get them in place, where necessary, even have perhaps some training opportunities for supervisors to be in place so that there can be that correct level of integration of PAs into the team. Because as we all know, the safest and best care is delivered by effective teams that work together. And anything we can do to improve that and take away some of the barriers that have given rise to the frustrations in the UK experience, I think are ones that New Zealand could well benefit from reflecting on.
And I guess we're lucky in that we have only 50 in New Zealand at the moment, so it's a new workforce, and so we have the opportunity at least to develop things. And it's good that the Medical Council is now involved, so there'll be some clear guidance, if you like, from them. But that kind of brings us on to, and we talked a wee bit about it before in terms of the liability. And Lucy, do you want to sort of expand in New Zealand as to where the liability lies? And
yes, well, it would be nice if I could, and I could tell you exactly. But obviously it's not clear yet. And it would be another thing that would be really nice to have clarified what responsibility is going to lie with the supervisor who is supervising PA, and that if they have complied with the guidelines of supervision and something goes wrong, will they still be held responsible? I think we also have to think about the situations where the supervisor is also the employer, and how that affects the supervision, because clearly there will be. If you're the employer, you'll have an interest in making sure that person is safely looking after your patients, but equally you've got your employment and vicarious liability as well, and so we need some guidelines. But I think, and it would be nice if the HDC would clarify for us as well. And obviously we haven't had that opportunity yet until we've got cases. How significant the liability and the responsibilities of the supervisor will be.
I guess we've had the situation where GPs who own a practice employ nurses, so that they're used to that kind of dual role of both being employer, but we probably do less supervision of nurses than what's going to be required for PAs, so that it is a different relationship, isn't it? Do you think there's an argument for saying that PAs should be employed by the government and paid independently, and take away some of that ambiguity of?
I don't know, Tim. No idea. I just think it needs to be clear, and I think that particularly if a doctor is not employing a PA and is asked to supervise a PA in general practice, that the employer of both the GP and the PA has a very clear understanding of what that supervision is, what the liability is for the doctor who's been asked to do that. And we've got to think about whether or not the GP wants to do that, and actually whether or not that's something that they are obliged to do within their role as a GP, or is it something that they can say, actually, I'd rather not. It's not my area of expertise. I don't want to supervise PAs. And
general practice is complicated enough as it is, without adding in a completely new skill, really, which is a completely new skill to provide good detailed supervision. What about practical things like ACC? Can PAs sign ACC forms in New Zealand?
Not at the moment, no.
Not at the moment.
and so at the moment, because they're unregulated, there is, if you actually look at what they can do as far as, they can't prescribe, they can't sign certificates, they can't order lab tests and things like that. We don't, in the UK, I understand that PAs can't prescribe in the UK. Is that right, Rob?
That's right. At the moment.
And I think in New Zealand, I think that's another whole question, because the regulation through the Medical Council will not change the ability of a PA to prescribe or not. That's going to have to be, that's a different piece of legislation that will need to be changed to allow that to happen. And I'm not sure how much appetite there is to do that. But the problem is, if you're actually wanting them to see patients who need prescriptions, the doctor who is then having to sign that prescription has still got to maintain the standards of the Medical Council for their own practice and good prescribing practice. And I think is probably a a difficult area for the doctors who are currently supervising is their responsibility as prescribers if the PA has seen the patient, not them.
But we currently have nurse prescribers within practices.
Yep.
So it would seem to be illogical that someone with a, what might be regarded as being equivalent sort of training ultimately doesn't have the ability to prescribe.
Yeah. Yes.
So that's something that
But they will have to change the legislation to allow that to happen. And the same with the ACC legislation. But I think that in general with regulation now, I think they're much better at understanding that if they're going to regulate, they will also change the ACC legislation at the same time. So hopefully that will happen.
But in terms of the HDC, even at the moment, even though they're not regulated, the HDC still has a role to play in
You don't have to be regulated for the HDC to criticise you. The HDC is allowed to criticise anyone. So no, they are still subject to possible investigation under the HDC.
All right. Well, look, there's a lot to think about with PAs in New Zealand. It's certainly, I think, very good for us to have had the UK experience and UK experienced PAs coming to New Zealand. Great assistance to us, and hopefully, we can learn from the experience in the UK and from the Leng report and take the best out of it.
I think that's right, Tim, and hopefully, as I say, I think the way we've done things in the UK hasn't been ideal. It's given rise to unnecessary conflict between professionals, which hasn't been helpful, at least of all to patients. And the other issue, I think, is the lack of research and good data on how PAs can fit into healthcare systems. So I would hope that in New Zealand you can have a chance to reflect on, firstly, how we've done things not terribly well in the UK. Secondly, are there bits of Leng that would be of use to you? I think it wouldn't necessarily all be immediately translatable, but I think there are some pointers there that you might want to think about. And certainly I would urge healthcare providers and researchers to think about this as an area of patient safety and so forth to get better data on, so that some of the decisions that can be made in the future are based on fact rather than some of the more emotive, anecdotal evidence that has brought us to this stage.
Certainly getting data would seem to be a very logical and important thing to do. Do you think there's much chance in New Zealand, Lucy, that we're going to get
it's so
good data
hard,
on?
and the Leng report talks about how hard it is to actually extract that data, where, especially in the current environment where people are seen by so many different providers, how you extract the input of any one health provider in their care, it's really hard. So I'm not sure. I don't know if anyone is doing any robust research on it. And it would be hard to, especially with them currently being unregulated, that it's hard.
And also it seems a bit unfair at the moment because we've got such a varied population but small population of PAs. But you'd think that maybe in the future, particularly if we're going to be starting training in New Zealand for PAs, that there'd be some part of that process would be to look at the outcomes and to decide, what are the good bits, what are the bad bits, how can it be improved?
And I do think it's towards the end of the report they were talking about what you need to do for change management, for effective change management, and one of the things they said, you need to have a clear vision and a goal. What do we do? What do we need? What does the healthcare team need? What do our patients need? What role can they fill that hasn't got somebody else doing that role already? That actually we need to find the right niche, and we all need to have a clear vision of what that means. The general population need to have a vision of and an understanding of what that means. So there's a whole pile of education, not just of the health workforce, but of everyone. And they talked about how really important it is to have strong leadership when you have anything changing. That actually, if you don't have a good leader who is communicating and engaging and listening to concerns and making people feel secure that the change is going to be good, then actually you may end up in a situation where everyone becomes more unhappy, which isn't going to help anybody, and particularly not our patients. So that whole most organisations aren't good at change management, and health organisations, which are so big and sprawling and difficult and complex, probably are worse than average at change management. And I think that's the challenge in New Zealand. How do we bring about change effectively and safely and with our patients at the centre of our thoughts?
And general practice, by its very nature, is little silos everywhere. So getting coordination across those silos has always been a challenge, but this is a particularly big one to have to deal with. Any other final thoughts there, Lucy?
No, my final thoughts are it's difficult. It's difficult, but that also that we have to, where there's a will, there's a way. I think our government has clearly signalled that this is where we're going. And so I think we have a really good opportunity now to do it right. So I'm hoping that that's where we will be.
Rob, final thoughts?
Yeah, I would echo Lucy's comments about change management. Maybe that's the bit of the Leng report that governments here should be looking at, because she says, at the moment, there's no inspiring description for how a new healthcare team might operate. And I think that was one of the things we got wrong in the UK. And I think if we can paint a new inspiring vision for how healthcare and primary care particularly is going to look like in the future, then that might go a long way to addressing some of the issues that we've discussed today.
And I think the impact of the PAs on the rest of the team need to also be, I think that in the UK with the junior doctors, where there hadn't been a lot of thought about what that was going to mean for junior doctor training. And I think I'm thinking about general practice in New Zealand because that's where mostly our PAs are at the moment. I think there's a fear that with GPs that they're going to be left with all the really difficult, complex stuff. And, we all like to have occasional consults that aren't hugely complex 96-year-olds, and so I think we need to actually look, as you say, at a vision of general practice that makes all the members of the team think, I want to be part of that, and I like the idea of that role, and I want to be doing that role, rather than slicing it into bits for convenience without actually looking at what it means for the individuals who are fulfilling those roles.
Great. Thank you very much, Lucy. Thank you, Rob. And thank you all for listening to this podcast, which I hope has been helpful. So our podcasts provide information of a general nature, and so if you would like advice on a specific case, and you are one of our members, of course, please contact us on 0800 22 556 677 and select option 3, and that's also 0800 call MPS, and again option 3, during business hours, of course. We look forward to catching up with you in our next podcast. And if you like these medical protection podcasts, please subscribe and leave a review. If you'd like a podcast on a specific topic, which would be great, please email nzpodcasts@medicalprotection.org.